We now come to one of the most meaningful and anticipated moments in this morning, the TCTAP Award, Master of Masters. It is presented to the individual whose career has not only advanced the field of cardiovascular medicine, but has also shaped the way we think, teach, and practice across generations. More details delivered by Dr. Seung-Jung Park. So, Dr. Park, would you please take the podium once again?
Okay. Welcome to the 16th TCTAP Master of Masters Award. Every year, it is great joy for me to present this award. And since 2011, the TCTAP Master of Masters Award has been presented to honor to the remarkable experts who have been making meaningful contribution to the field of intervention cardiology and to the growth of our meeting, TCTAP. Here are actually our past 15 masters. I would like to extend my genuine appreciation for their expertise and dedication. So the last three is Roxana Menon. So this year's winner truly reflects the spirit of this award. He is globally respected cardiac surgeons and clinical leaders whose work in the art trials, arterial grafting has greatly advanced our field. So let us know watch a special video to find out who is the winner of 16th TCTAP Master of Masters Award.
In 1958, in the United Kingdom, a boy was born. Filled with endless curiosity, he became fascinated by the intricate structure of the human body and carried a deep desire to transform the lives of those in pain. That desire became his guiding compass. While studying medicine at the University of Glasgow, he quickly distinguished himself, developing a profound interest in the heart and advancing to the Royal Brompton Hospital, where the world-leading cardiac surgeons gathered. There, he explored both the potential and limitations of coronary revascularization, marking the true beginning of his journey toward better surgical care. Dr. David Paul Taggart currently serves as Professor of Cardiovascular Surgery at the University of Oxford. His dedication to delivering the best treatment for heart disease deeply resonates with the spirit of TCTAP, which continues to pursue better patient care.
Dear Deb, it is my great honor to congratulate you on being the 16th recipient of a TCTAP Master of Masters Award. Your pioneering work in cardiology has great influence how we treat coronary artery disease today. Because of visionary leaders like you, cardiovascular care continues to improve for patients around the world. So David, congratulations once again on this very well-deserved honors, and thank you for everything you have done for our field.
One of his greatest achievements is the ART, the largest randomized surgical trial ever, performed in the use of CABG for intervention in coronary artery disease. Randomized over 3,100 patients, allocated to single or bilateral ITA grafts, the trial is now being analyzed after its 15 years of follow-up, demonstrating the survival benefits of multiple arterial grafting and ultimately transforming cardiac surgery guidelines worldwide. He also co-founded the ICC and ISCAS with Dr. John Puskas, leading coronary surgeons across the globe.
He was the PI, originator, and visionary that launched the ART trial, the Arterial Revascularization Therapies trial, which at its time was the largest coronary surgical trial in history. Now to see him recognized by TCT Asia Pacific as one of the visionaries and leaders in the entire field of cardiac care, frankly, it's a wonderful thing. It's not a surprising thing. It is a richly deserved acknowledgement of a lifetime of contribution with a laser focus on improving outcomes for patients with coronary artery disease.
When it comes to on versus off-pump CABG and multi-arterial grafting, not only are you a fantastic technical surgeon, but you have a brilliant analytic mind. Now I know how much this award today means a lot to you, because it's typically awarded to cardiologists, and the fact that you are receiving it today as a surgeon is a huge testament and recognition to your amazing contributions in the field.
However, Dr. Taggart's journey did not stop with a single clinical trial. In the ongoing debate between CABG and PCI, he has consistently spoken with a voice grounded in data, and that debate has always been directed toward better evidence and better patient care.
It's been a privilege to debate you over the last many years on PCI versus CABG. As you remember, those debates were not just spirited, they were entertaining, and I must point out they were sharpening moments for everybody in the room. Your rigor, clarity, and willingness to challenge conventional wisdom has definitely pushed the field forward and ultimately benefited our patients. That influence, according to me, is what this award really celebrates.
You are considered a bit controversial. However, without controversy, how can we ever make any progress? You've been a thorn in the side for interventional cardiologists. I've had fun debating with you, but you pointed out some of our shortcomings and the value of bypass surgery. And even though you're controversial, or maybe because you're controversial, you've been enormously valuable to this course over many, many years. Again, congratulations.
His influence has extended far beyond the operating room and the laboratory, reaching into a broader world. Transcending the boundaries between surgery and interventional cardiology, he's paved the way for true collaboration in the service of patients. Earning deep trust and respect from both colleagues and the next generation, he is widely recognized as a true leader across disciplines.
I have admired what you have done over the course of the year, really showing the way, showing the right path for coronary artery bypass surgery. And as far as I am concerned, I feel privileged and honored to have had a small part in your career and to call you a friend and a mentor.
I know David for many, many years, and he has been a pioneer bridging the interests of cardiovascular surgeons and the interventional cardiologists. He has been very balanced, very insightful, very scientific, but at the other side, very, very practical in his recommendations dealing with valvular and coronary heart disease.
Dear David, congratulations for this important award. Your contribution in the field of interventional cardiology from the surgical side have been fundamental. Thank you. Thank you for what you have done and what you are doing.
Dr. David Paul Taggart is a true pioneer who has expanded the possibilities of cardiac care. His unwavering commitment to better treatment continues to inspire us all. The legacy he has left in this field lives on today in operating rooms around the world.
Congratulations, ladies and gentlemen. Please welcome our Master of the Masters 2026, Dr. David Paul Taggart, to the stage. With a big round of applause. Dr. Taggart, would you please come up to the stage? Congratulations, a surgeon, a scholar, and above all, a master of his craft. Dr. Taggart's contributions have left a lasting mark on cardiovascular surgery worldwide. Congratulations. Why don't you give another big round of applause? Congratulations. On behalf of TCTAP 2026, it's our great honor to present the Master of Masters Award to to Dr. David Taggart. Thank you very much once again. Thank you. So, of course, we would like to take a commemorative photograph to record this precious moment. Thank you very much once again. And Dr. Taggart, yes, would you please share with us your feelings and the lectures? Please take the podium. Congratulations once again. His work has guided countless clinicians. Thank you very much once again.
Well, good morning, ladies and gentlemen. I'd first like to thank the Foundation and Dr. Parks in particular for the invitation to be back in this great country. Clearly, I'm very honoured and privileged to receive this award, and indeed really quite humbled considering the very eminent and illustrious previous recipients. So I'm going to talk about 6 decades of coronary revascularization and what lessons have we learned. And I have no conflicts of interest except as a cardiac surgeon. I'm going to start with this important general caution regarding pharmaceuticals and medical devices. And this is by a previous editor of the New England Journal of Medicine, Marcia Angel, in 2009. She said, conflicts of interest and biases exist in virtually every field of medicine, particularly those that rely heavily on drugs or devices. It is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine, and I will show how those prophetic words from 2009 are as relevant today as they were then. But I would add 3 specific cautions to those warnings of Dr. Angel when you're interpreting data from trials of PCI and CABG. The first and arguably most important question is, are the trial patients typical of routine practice in terms of coronary artery disease severity? And the answer is usually no. It's usually very highly selected patients. And this therefore serves to underestimate the benefit of CABG in routine practice, where most patients have more severe coronary artery disease. The second important consideration is what is the duration of follow-up. It must be a minimum of 5 years, and ideally should be at least 10 years. Because what we see is with increasing length of follow-up, there is increasing benefit of CABG. And it's important to note that 80% of CABG patients are still alive at 10 years. The third consideration is, did the CABG patients receive guideline-directed medical therapy? Because in most trials, optimal medical therapy is given to PCI patients. And the importance is that although CABG does do generally better than PCI, with optimal medical therapy, those results would be even more relevant. And the other tip I would give, if you're ever reviewing a manuscript or reading it for your own information, always look at the results in the tables before you read the text, because the text will very frequently have a pro-PCI bias. Now, if you look at the 2 giants of non-pharmacological coronary intervention, the first is René Favaloro, widely acknowledged to be the father of coronary artery bypass grafting. He wasn't the first to do CABG operations, but he was the first to produce systematic reports and changing it into a mainstream operation. And this is a beautiful picture of him with the great radiologist Dr. Mason Sones in the Cleveland Clinic in the 1960s. And the father of interventional cardiology is undoubtedly Andreas Grunzig. He did his first clinical angioplasty on September the 16th, 1977, and the same year presented 4 cases at the AHA and revolutionized the understanding and treatment of coronary artery disease. And this is a paper by his former trainee, Bernie Myers, showing the first patient who had angioplasty in 1977 at 23 years follow-up, almost perfect result. So why did I get interested in this area? It had been troubling me that the reporting of trials of PCI and CABG weren't really representative of what was happening in clinical practice. And Pocock and colleagues published a meta-analysis of 5 randomized trials in The Lancet in 1995, claiming no difference in prognosis between these 2 initial vascularization strategies. I responded to that a few months later saying I didn't think this was the correct interpretation because almost 90% of patients had been excluded from the trials, and the trials were largely populated by patients with 2-vessel disease and normal ventricular function, very different from what was happening in clinical practice. And I substantiated this a decade later in this paper. CABG is still the best treatment for multivessel and left main disease, but patients need to know. And I'm very proud of that title because I still think it's highly relevant to today's practice. And what you can see is in the 15 trials, which comprised around 9,000 patients, only 1/3 had 3-vessel disease and only 40% had proximal LED disease. So these patients were very different from what was actually happening in coronary bypass grafting. Nevertheless, these highly selected trials were then used to generalize to all patients with coronary artery disease and to influence subsequent guidelines. Now, if you look at what is still the most important trial of PCI and CABG, it's the Syntax trial for multivessel disease. The results were published in 2013. Around 1,000 patients, and you can see at 5 years a significant reduction in death, myocardial infarction, and repeat revascularization in the CABG group. But also, these papers were then divided, the patients were then divided into severity of disease by Syntax score, and only around 21% of patients had Syntax below 23, and they had a 1% survival at 5 years. If you look at the intermediate group, the difference in survival was 7%, and if you look in the high severity group, the difference was 9% at 5 years. And these were all accompanied by marked reductions in myocardial infarction, repeat revascularization, and no difference in the risk of stroke. And why was Syntax so important? Because it was the first trial to try and address the limitations of the previous trials, which were very highly selected patients. Nevertheless, bear in mind, even in Syntax, 40% of patients went into the registry because they were largely deemed ineligible for PCI, and 84% of these patients had CABG. And if you follow these patients out to 10 years, you can see the survival benefit of CABG continues to accelerate with a hazard ratio of almost 40%. Patrick Sroy's group published this paper looking at the outcomes of both the randomized trial and the registry and concluded, according to Syntax Score 2 2020, only 1 in 5 patients in the Syntax study could expect a 10-year survival benefit from PCI compared to CABG. And the other important thing about this was, if you look at the mortality in the registry group for CABG, where the patients had much more severe coronary artery disease, it was the same as in the randomized trial. So CABG mortality is similar for any severity of coronary artery disease. Now, in an attempt to address 2 perceived limitations of Syntax, we have Dr. Fearon today, the main PI of FAME3. And what they looked at was 1,500 patients with not using the old generation drug-eluting stent and addressing the fact that there had been no FFR. Now, in this trial of 1,500 patients, the mean Syntax score was only 26, and the primary endpoint was death, MI, stroke, and repeat revascularization. And at 1 year, PCI failed to meet the criteria for non-inferiority. The 5-year results were published in The Lancet in 2025, but now the results were presented as a composite of death, MI, and stroke, saying no difference between PCI and CABG. But what was really surprising was that this endpoint was changed from the original primary endpoint, which should have been the main focus of this paper, because it still showed a highly significant benefit of CABG over PCI, even in these patients with relatively low syntax scores. If you turn to left main, back in 2008, the proposed wisdom at the time was that CABG should remain the preferred therapy for most left main stenosis. And this was predicated on the following: up to 90% of left main have multi-vessel disease, where CABG already offers a survival benefit. Up to 90% of patients have distal bifurcation lesions, which, as we said at the last session, are at much higher risk of restenosis. But what we also noted was there were excellent PCI outcomes for isolated ostial and mid-shaft lesions, and probably even better than the results for CABG. If you then look at what's happened since there, the first randomized trial for left main disease was the pre-combat study, 600 patients, and this was based on the preliminary findings of Dr. Park's main compare registry. But again, note that 80% of these patients had low or intermediate disease, and there was no significant difference in outcomes at 1 or 5 years, with the exception of markedly reduced repeat revascularization for CABG. And a few years later were the outcomes of the left main cohort of the syntax trial, and it showed very clearly, with scores up to 32, there was no difference at 5 years between PCI and CABG, but after 5 years, there was a marked benefit of CABG over PCI. And this was very important because it was used to define the entry criteria to the XL trial, being scores less than 33. And it also raised the question, if you only had left main and not additional proximal coronary disease, was there too much competitive flow for bypass grafts? So I turned to the XL trial, the largest, most definitive trial of PCI versus CABG. It recruited 1,900 patients of a proposed 2,600. Enrollment was stopped early. The patients had a mean syntax score of 26, so low intermediate patients. There was a 1,000-patient parallel registry at the start of the study, of whom 71% of patients were ineligible for PCI, so they went straight for bypass grafting, again showing that the patients entered into trials may not have the same severity of disease as what we witness in routine clinical practice. The mean age of the patient, 66 years, so a life expectancy of 15 to 20 years. The primary outcome was a composite of death, MI, and stroke, but not repeat revascularization. And the trial used a new biochemical definition of myocardial infarction, but did not include the universal definition data. And why is that important? Because if the universal definition data had been included, the results of the 5-year outcome would have been overall very positive for bypass grafting. Now, we've got Adrian Banning here from Oxford, and I congratulate my cardiology colleagues and my surgical colleagues, because we were very determined to enter this trial properly. And in fact, we were the second largest recruiters worldwide, with just under 100 patients. So we were very heavily committed to the XL trial. But what did it show? The most important thing it showed was at 5 years, a 4% difference in mortality in favor of CABG. But what is really crucial about this, if you look at the shape of these survival curves, you can see there's a sharp divergence that is accelerating past 5 years. So not only was there a statistically significant risk in the rate of death, with PCI, there was a marked increase in non-procedural MI, and CABG also reduced the risk of repeat revascularization and no difference in the risk of stroke. The conclusions of the manuscript read, in patients with left main coronary disease of low or intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to the rate of the composite outcome of death, stroke, or MI at 5 years. Initially, the editor of the New England Journal insisted mortality should be the central focus of this paper. I agreed with that, but when that did not happen, I withdrew my authorship from the paper. And the other thing we must critically know here, I mentioned the importance of 10-year follow-up. Where you have a sharp divergence at 5 years, it is absolutely imperative we know what happened to these patients at 10 years. Since the Excel trial, there have been furious attempts in the literature to overturn the results of Excel. There have been several meta-analyses, and probably the best done is this individual patient analysis from Mark Sabatine and colleagues. They looked at 4,500 patients from the 4 randomized trials, but notice the median syntax score was 75. So this is a low intermediate cohort, not representative of routine clinical practice. And what they showed was no difference in death, but marked reduction in MI, repeat revascularization with CABG, and no difference in the risk of stroke. But if you look at the landmark analysis of this study and look at what happened after 1 year, you can see that there is then a rapidly diverging difference in the risk of the cumulative outcomes in favor of CABG. And I would complain that this manuscript title gives no indication that the results are of a very highly select group of patients entered into the trial, and they're consistent with what syntax showed for scores below 33. What about 10-year outcomes? This has been answered well in 2 studies, again of patients with relatively low syntax scores, pre-combat 10-year outcome, equivalent survival, same for the Noble trial at 10 years, and both of these studies, however, did show a marked increase in the need for repeat revascularization. But I've also pointed out the trial that we must see the outcomes at 10 years for is Excel, and we haven't seen those. So I would give 3 reasons why, despite the enormous technological advances in stenting over the last 2 decades, PCI still fails to equate to CABG. And the first is that anatomically, atheroma is mainly located in the proximal coronary arteries. So placing bypass grafts to the mid-vessel means that the complexity of the proximal lesion is irrelevant, and it means that CABG offers future prophylaxis against development of new proximal disease. PCI does neither of those. The second important consideration, published by Tom Lusher in the New England Journal more than 3 decades ago, was that the internal mammary artery elutes nitric oxide and other potentially vasoactive mediators into the coronary circulation and reduces the risk of further disease. In contrast, a drug-eluting stent impairs re-endothelialization, causes downstream endothelial dysfunction, and creates a prothrombotic environment. And the third difference is PCI means incomplete revascularization for many patients. And this has been repeatedly shown to correlate with subsequent adverse outcomes in terms of mortality and other MACE. So I would argue that PCI is unlikely to ever match the results of CABG for most patients with left main and multi-vessel disease. It didn't do with POBA. It didn't do with bare metal stents. It hasn't done so with drug-eluting stents, and it hasn't done so with the new generation of drug-eluting stents, even in patients who had relatively low severity coronary artery disease. So in the last few minutes, I want to talk about PCI-CABG ratios around the world. The first is this paper in 2014 looking at 14 countries of the ratio of PCI to CABG. And overall, the mean ratio was 3.3 to 1. But there was a 15-fold difference in that range, depending on which country you were in. And even in Europe, there was a 4-fold difference between 2 in the United Kingdom and 8.6 in Spain. And the ratio in the South and Far East is estimated to be around 20 to 1 PCI to CABG. In a more recent update of this data published in the BMJ, looking at per 100,000 patients, most were elective, although it did include some acute myocardial infarction. They're all working off the same evidence basis, and yet the ratio in these countries vary from 3 to 1 to almost a 4-fold difference at 11 to 1. But it's not just between countries. If you look at the same region of one country, Ontario in Canada, they looked at 14,000 patients in 19 centres, treated between 2013 and 17, and followed for a mean of 3.3 years. And what they found was that the PCI rate in comparison to CABG was much higher if the diagnostic angio was performed only by an interventional cardiologist, where there were no heart-themed discussions and where there was no cardiac surgery on site. And these different rates of PCI versus CABG correlated subsequently with a significantly higher risk of death, MI, and repeat revascularization. So if we go back to 2018 ESC EACTS guidelines, these were very clear, pictorially well represented, and the major points they made were that for left main disease, 2/3 of patients in clinical practice had a syntax score above 33, a class 1 recommendation for CABG, class 3 for PCI. And if you look at patients 3 vessel disease without diabetes, almost 80% of patients in clinical practice have syntax scores above 22, with a class 1 recommendation for CABG and class 3 for PCI. And those benefits of CABG are further accelerated in patients with diabetes and impaired ventricular function. Now, the beauty of these guidelines is that they're evidence-based, intuitive, very easy to follow, assuming that a patient is suitable for that procedure and accepts the expert recommendation. And I would argue that the results of CABG would have been even better if there had been more arterial grafts and optimization of medical therapy. Then in 2021 was this bombshell from the ACC-AHA, which then looked at CABG recommendations, and they significantly downgraded the class of recommendation for CABG from 1 to 2B for normal ventricular function and 1 to 2A for moderate LV impairment. They did this without any new evidence to support these changed recommendations. They largely based it on the ischemia trial, which was not a trial of PCI versus CABG, and they ignored the enormous body of existing literature about the benefits of CABG, some of which I've already alluded to. Now, these guidelines were formally rejected by every society of cardiac surgery worldwide. And I would argue they were a real danger to patients, because read by the non-expert doctor, it means a lot of patients who could have benefited from bypass grafting would no longer be referred. In 2023, the ACC-AHA tried to roll back a bit on this in this publication, but again did not restore CABG to its previous recommendations. The only 2 surgeons in this original writing group resigned from the paper. So if you now look at 2024 ESC-EACTS guidelines, one of the experts you'll see in this is Adrian Banning from Oxford, written by 28 experts from 13 countries, reviewed by 43 experts from 22 countries. And they largely restored the previous recommendations from 2018 of showing the benefits of CABG in 1 or 2 vessel disease involving proximal LAD, 3 vessel disease with or without diabetes, multi-vessel disease, left main with or without multi-vessel disease. And again, when you look at this table, you have to read it line by line. So it is not as elegant or as simple as the table in 2018. Nevertheless, these ESC-EACTS guidelines have now been approved by every major society of cardiac surgery, unlike the ACC-AHA guidelines. So to summarize and conclude from a surgical perspective, we've had 60 years of CABG, 50 years of PCI. The evidence basis for both procedures is robust and clear, with few exceptions, and I mainly mean the syntax trial. Trials of PCI versus CABG have been designed to deliver predictable outcomes by selecting patients with low severity coronary artery disease so that you know the results before the first patient is even randomized. The trial patients were highly selected and then often misleadingly presented as if those results applied to the general population with coronary artery disease. I've explained the 3 fundamental pathophysiological differences between the procedures. that explained the enduring benefit of CABG despite very significant improvements in stent technology. I pointed out the significant differences in PCI CABG ratios around the world and with the same region of different countries, and yet they're all based on the same evidence basis. And I would say that the only explicable way of explaining this is these recommendations are often based on physician preference rather than the evidence basis or patient interest. And the only solution is that all interventions being done in the acute or urgent situation should be agreed by a multidisciplinary heart team. Now I'm going to finish with the words of the great Andreas Grunsig, since this is predominantly a cardiology conference, which you know died tragically young in an airplane accident. And he wrote in the New England Journal in 1979, we estimate that only about 10 to 15% of candidates for bypass surgery have lesions suitable for this procedure. And I would say he got his numbers just about right, because if you look at the syntax scores below 22, it's about 20% of patients. And then he called for, as predicted, the need for randomized trials. And we'll finish with this editorial published in The Lancet in 2005 by the great Lionel Opie, Patrick Comerford, and Bernie Gersh, three very eminent cardiologists. In view of the survival benefits shown for coronary artery bypass grafting, the real controversy is why patients with symptoms and anatomy known to benefit from the procedure are still submitted to percutaneous coronary intervention. On that point, I'm going to conclude my talk. I would like to thank the Foundation again for the great privilege and honour of receiving this award today, for Dr. Park and his colleagues for inviting me, and finally to you, the audience, for your attention. Thank you.
Thank you very much, Dr. Taggart. Why don't you give another big round of applause to our Master of Masters 2026. Thank you very much. Yes, Dr. Taggart, for your inspiring lecture and meaningful reflection. We quite gratitude and congratulations once again on this prestigious recognition. It's been a great pleasure to share this special moment with all of you today, and we hope the insight and inspiration from this opening session will continue to enrich your experience throughout the rest of TCTAP 2026. And we'll have the exciting lineup of sessions and activities prepared for you throughout the day. So please enjoy the program, and also please feel just the heartbeat of this country. And I'm sure yours requires no supervision. So thank you very much once again for joining us today. We'll wrap up the opening ceremony. Thank you. 감사합니다.